Good afternoon. I'm Beth Stroll, and on behalf of the TA Network for Children's Behavioral Health, I'd like to welcome you to this month's session of the System of Care Leadership Learning Community. Denise Solzbeck and I co-lead this learning community, which meets monthly and is designed to support System of Care leaders in all roles, whether it's SAMHSA grantee directors and coordinators or leaders in content areas or leaders in states and communities and tribes without SAMHSA grants, and any others with leadership roles in system of care implementation or expansion and sustainability. We try to address topics that are important to leaders, and we really want this to be interactive. So I encourage you to use the chat box throughout the session for your comments, for your questions, and feel free to introduce yourself in the chat box by putting your name and where you're from so that we can get an idea who's with us today. Before we get started, I'd like to mention the next Learning Community session, which will be on October 25th, and we'll be focusing on state-community partnerships for system of care expansion. So we hope that you'll be able to join us for that one. Our topic today is Beyond Impact Statements, Addressing Behavioral Health Disparities. And the session was really designed to help apply the information that you gathered for impact statements to eliminate disparities in access and outcomes to behavioral health services. So we really want this to focus on how you apply the information that you've collected and the strategies that you design for your impact statements. We are very fortunate to have Peter Gamache as our presenter today. Peter works with the Cultural and Linguistic Competence Hub of the TA Network, and he's a program designer and evaluator for initiatives that focus on underserved populations and on disparities. The objectives today are for a discussion of the need and rationale to address disparities that look at access, service use, and outcomes, also to discuss how to assess disparities and how to create an impact statement, to describe strategies to address behavioral health disparities, and then also to discuss how to gather and interpret and use data on disparities on an ongoing basis. We want to emphasize that this is applicable to SAMHSA system of care grantees, but to any jurisdiction also that's working on addressing disparities in their service systems. One of the major reasons for focusing on this is that the face of America is changing, that the demographic trends and visibility in the population of the United States shows that we're increasingly diverse, and that this, of course, leads to an increasing need to address disparities and disproportionalities. This slide shows trend data from the U.S. Census, and you can see that from 2000 to 2010, there was a 32% increase across the country in areas that have 2 or more races as a percent of county populations. So this shows you just how diverse our population is becoming. And with that, I'm going to turn this over to Peter.
So what is contributing to the intermixing of the population in terms of more than one race? Well, part of it is the intermarriage trend. And so we can see, for example, in the graph to the very left, and this is from the Pew Research Center, it shows that there was a semi-recent major increase of intermarriage trends from 1980 to the year 2010. And this is, again, all based on U.S. Census data. And so, for example, new marriages were at 6.7% in 1980 of people, of spouses from a different race or ethnicity from one another who were marrying, compared to more than twice that percentage in 2010. So we see this very major increase, steep climb in the intermarriage trend. And in the middle of the slide, we can see the acceptance specifically of blacks and whites that were dating each other. And this is semi-recent. Again, it's 1987 through 2009. And so they were able to plot or graph 40, in the 40% range upwards to the 80% range. So it really, again, we're looking at doubling or near doubling over time. And what's driving this is really the youth. So if we look at the specific age decade breakouts, and we can see, for example, on the chart on the right, that youth have a much higher supportive stance on people of two different races or ethnicities marrying one another, and you can actually see the difference by decade. So the youth are in the the 80% ranges, and then you can see that it actually declines like a staircase with each for the older generation. So really, the youth are the ones that are driving this attitudinal change, the acceptance of people dating and intermarrying one another. So very interesting trends that we're seeing in terms of demographics. And another contributor to this was, of course, the U.S. Supreme Court decision. In 1967, they declared that it was unconstitutional for states to have what was called anti-miscegenation laws, where it was illegal for different races to marry one another. So that was struck down by the court in the case Loving versus Virginia in 1967. So we have structural changes across the United States, and then we have attitudinal changes that are driving these population trends. And another major population trend across the U.S. is the growth of the Hispanic or Latino population. This is a graph from the Georgetown Public Policy Review, for example, that shows brightly colored areas of the map that show there are higher densities of people who are Hispanic or Latino. And even in some areas that kind of look like there aren't people living in there, if you were to zoom in on specific states, then you would find clusters of brightly colored areas as well. But this is the kind of zoom back map that shows the U.S. Population overall. So these are major trends that are happening to the diversity of the population. We also have the data, as I mentioned, from the 2010 census on same-sex households and same-sex households raising children. And there were some really interesting responses that came out from this. This is data that were the data that were crunched from the Williams Institute. They basically, if you Google the Williams Institute, you can find their websites, and they have wonderful clickable maps where you can look at the national overall maps that show where people responded that they were in a same-sex household or a same-sex household raising children. And so you can see from the national map at the top left that there's really across the United States, all over the different areas. And then in some areas where you might not expect to see that people are at a high density raising same-sex couples raising children, that even within certain counties or zip codes, you can find that they are there. So in systems of care, sometimes when we're drawing attention to the needs of minority and underserved populations, sometimes there's a reaction that we'll experience where people will say, well, we don't really have those people that live around here. We don't have same-sex couples. We don't have people of whatever specific ethnicity or race. But if you look at the data, right, and just objectively look at the data, it will show that indeed there are people in your local catchment area or service area for your system of care that are part of these groups. And there's an article here that I thought was very interesting. This is from the Jackson Free Press. This is a news source. They indicated, actually reported what the U.S. Census reported, was that Mississippi leads the nation in the percentage of same-sex parents. Right, so that was surprising to some people in our areas that we work with. So it's just very interesting when you have an objective use of data that is put forward, then you can see that these trends are growing and that they are certainly being more visible within the area. Another rationale for looking at disparities is to address the gaps that are within and across service systems. So for example, on the left here in this slide, it depicts the child system, and then the transition age right in the middle in that blue bar. And again, this is just an illustrative example. 14 to 21 is, it can be depicted as a transition age youth. And I know that the numbers, right, the specific age ranges have changed over time, and depending on where you are or how things are classified. But that's just a kind of general range. And then we have the adult system. So when we have gaps, right, across these systems that are addressing, monitoring, and evaluating inequalities, right, inequality in terms of access to services, inequalities in terms of the use of services, and the outcomes based on services utilization, then what we find is that there's trends across these systems. In the child system, as youth are involved with special education, for example, or child welfare, juvenile justice systems, or child mental health systems, right? As they transition across, and many move into the adult systems, unfortunately, we have criminal justice in the adult system, we have adult mental health systems, institutionalization, we have housing challenges, voc rehab needs, and substance abuse challenges. So if we don't address the gaps in the systems earlier on, then what we find is that there are disparate outcomes among those populations as they transition into those adult systems. And another rationale is that addressing disparities or these gaps is certainly embedded in the system of care values and principles. System of care upholds the principles that the services are family-driven and youth-guided, they're community-based, culturally and linguistically competent, and data-informed. So those are the core principles of systems of care, and that's why addressing disparities is a real need. And there are many research studies. This is one reference that's provided that showed that addressing gaps can yield improvements in overall quality and efficacy of care, health and well-being outcomes, quality of life, for example, communication and trust between clients and providers, provider knowledge and skills, satisfaction among clients and providers, as well as declines in medical and mental health disparities, provider bias and discrimination, delays in seeking services, and also costs, right? So this is very costly when we have gaps in these systems and how people are not doing as well as they can that are being served by them. So let's talk about some exact language, because sometimes the specific words or terms that we use are conflated or kind of overlap sometimes, where, for example, many people will say, well, that's a disparity, and then actually it's technically not a disparity that they're describing, but it's a disproportionality, and vice versa. So I think it's important to just examine the specific words that we use, because these are, it's like what's been described as the language of power, right? So if you can specifically identify a need and characterize something and measure and monitor it, well, then you have the power to be able to make those changes. So a disparity is an inequality that's marked by a comparative difference. So for example, if we were to say males versus females have differences in their access to quality care, or you're comparing one group side by side with another group, that's a disparity. That's basically an easy comparison between two different groups. And then there's the other term that's called disproportionality. I know it's a long word and it looks kind of even technical, but it's a specific way to describe the needs of the population that you're working with. A disproportionality is skewed representation of a given population group despite comprising a minority of the overall population. So what do we mean by this? For example, if we were to say African American men represent a majority of new HIV infections, but are the minority of the overall population, right? They're disproportionately impacted by a certain chronic condition or behavioral health need, for example. That's a disproportionality. They're disproportionately impacted, right, in comparison to their sort of representation in the overall population. So let's do a poll on this. I think it's interesting to see the responses that come through, because it can be tricky to kind of parse these terms. What would we say if we were to say this is an example of a disparity or a disproportionality? If we were to say that racial and ethnic minorities endure higher rates of morbidity and mortality than non-minorities. If we were to make that statement, what would this be an example of? Is it a disparity or is it a disproportionality? And we're going to just do a quick poll, interactive poll for you all to click on and vote for. What do you think? Okay.
The poll should be coming up. I'm not sure if we're still having some technical issues. Why don't you move ahead and let's see what we can do about that.
Okay.
Sorry,
So
Peter.
if we were to look at this and ask ourselves, is this a disparity or disproportionality if we're comparing racial and ethnic minorities in comparison to non-minorities? This is a disparity. It's an inequality marked by a comparative difference, right? That's essentially what a disparity is. And another example is if we were to ask the question that racial and ethnic minorities experience greater challenges accessing behavioral health services compared to non-minorities, would this be a disparity or disproportionality? If we reflect on that for just a moment, what does this represent? Well, this is another disparity because it's, again, an inequality marked by a comparative difference. So what if we were to ask the question, a local detention center confines a higher number of African American and Latino youth compared to the racial and ethnic makeup of these African American and Latino youth within the county, the surrounding areas that the detention center is located in. So this is a disproportionality. Why? Because it's skewed representation of a given population group. So the way that I kind of try to remember the differences between the two terms is with the disproportionality, it's basically looking at a pie chart, a proportion of the overall pie, right? So if a racial or ethnic minority, for example, comprises, let's say, 15% of the population, or a minority of the overall slice of pie, right, then if we were to then look at their outcomes that would be disproportionately impacted, right, let's say that they have greater challenges or needs or they're having issues in terms of underrepresentation or overrepresentation in certain service systems, what we're really describing is a disproportionality, right? So these are specific terms that can be used in terms of looking at population-based needs. So it's the right thing to do this. It's a quality way to look at programs and systems of care services. It's also because it's tied to the funding. That's also a major rationale. It's increasingly required by public funding agencies. SAMHSA is one example. They have different grant programs and cooperative agreements, for example. System of care expansion and sustainability is certainly one major prominent funding channel that requires services to be looked at or examined in terms of their disparities among population groups. There's also other areas of their portfolio for HIV programming, for offender reentry programming, people who have lived in incarcerated settings and they're returning to their communities, the grants for the benefits of homeless individuals and supportive housing. There's lots of different areas of where there's requirements within the funding opportunity announcements. And so each one of these funding opportunity announcements require that the project will have a behavioral health disparities impact statement. And another rationale is that private funders also frequently ask about these exact types of things. For example, foundations and other opportunities where funding can be sought, private organizations that have different ways that nonprofits and other service systems can apply for funding. They will require that there's a diversity and inclusion of clients to be served, that there's diversity and inclusion of key staff, for example, peers, or the meaningful involvement of individuals that are served. And then there's also the diversity and inclusion requirements sometimes that you'll see with boards of directors of organizations. So they'll have organizations or applicants to fill out things like tables or grids or diversity tables, for example, to show the representation by race or ethnicity or gender. So having data like this it has multiple purposes, and diversity and inclusion are always good for business, right? So there's the public funding side of things, and then there's also the private funding side. So these are major rationales for why this is important. And so some of the methods that can be used for addressing disparities and disproportionalities include developing a needs and resources assessment. So for example, before even a proposal is put together, having data that are available in your catchment area by race, ethnicity, gender, sexual orientation, for example, this can be used for the funding application. And then the funding opportunity announcement is provided in terms of the response to the proposal saying that something was funded, congratulations, and that will typically also have terms and conditions of the award. And so there's the Notice of Grant Award with specific requirements. There's the Behavioral Health Disparities Impact Statement submission. And then there's the implementation of strategies and ongoing continuous quality improvement. So all of these steps are parts of what the systems of care really are, the model systems of care do, right? They have data that shows the needs in their specific catchment area. That is Section A, for example, of the funding opportunity announcements proposal. Then post-award, there's the funding, the response to it. And then there's the creation of the Disparities Impact Statement that is required to be submitted to the government project officer. And then there's the use of these statements on an ongoing basis. So this moves from a process-related collection of data to looking at outcomes throughout the program or the project. So this is required for SAMHSA grantees, is to deliver services of cultural linguistic competence to address behavioral health disparities among racial and ethnic minorities in terms of access, service use, and outcomes, to integrate with alternative or traditional healing practices, and to identify a task lead for cultural and linguistic competence. And in the little box here that's shown, this is literally the specific requirements from the funding opportunity announcement that required the applicants to submit Section A. Again, it's the population of focus and statement of need, where the actual proposal needed to specifically outline the needs of the population of focus in terms of their race, ethnicity, federally recognized tribe, language, gender, age, socioeconomic status, and sexual identity, sexual orientation, and gender identity. So the reviewers of these proposals are literally looking for those specific items when they're scoring these proposals. And so, for example, there are tables that are provided that can help to outline this for the reviewers and for for the project team, where they're outlining how many are going to be served, how many individuals will be served per fiscal year and total overall by race, ethnicity, by gender, and by sexual orientation and gender identity. And the Appendix E of the funding opportunity announcement specifically provided the rationales or the sources, and you can visit these links and follow them along, to the level of your ability and interest for why this is important. So SAMHSA is basically lining up with the U.S. Department of Health and Human Services action plan to reduce racial and ethnic health disparities, right, as well as Healthy People 2020 and a lot of other federal mandates and requirements. So this is an example of the terms and conditions of award, the Notice of Grant Award, and specifically it says that a behavioral health disparities impact statement is required, and there are certain sections, right, A, B, and C, for the grantees to put together and submit into SAMHSA. And so Section A is to outline those disparities of the population of focus that will be involved in the project. And then Section B is to basically outline the data collection activities that they will be inclusive of those populations of focus, the program services and activities that are going to be developed and implemented to serve them, and then the data reporting, including their access, use, and outcomes measures, right? So lots of times that we will see that there will be questions about how to collect certain demographic categories. And so technical assistance is available to, to help with this process. And then the Section C is the plan for the development and implementation of policies and procedures to ensure adherence to CLAS standards, and we're going to talk about this in a little bit, and how basically the services will be responsive to the diverse cultural health beliefs and practices, preferred languages, and health literacy and communication needs of these populations. So how do you get started when you start doing this, right? So congratulations, you've been awarded this this agreement, this cooperative agreement, or this grant, and now you're to submit a behavioral health disparities impact. How do you get started? Well, the behavioral health disparities impact statement, the purpose of it really is to assess and heighten the impact of policies, programs, processes, and resource decisions to reduce and ultimately eliminate behavioral health disparities. That's the whole point of it. Behavioral health data, we know, are often isolated in agency silos. Sometimes it's for reporting requirements. Sometimes it's to address a certain policy. But really, data are ideally gathered on identified disparities and disproportionalities to address differences. Right? At the core of this, we're looking at differences in access, service use, and outcomes by these populations, according to these populations. So we can see, for example, that certain racial and ethnic groups, for example, are not utilizing services to the extent that they can, in comparison to other groups. And then raising the question of, well, why is that? What is going on here? Maybe that we need to, sort of adjust our strategies or what we're doing in our program. And then this is going to lead to continuous quality improvement strategies. So when you've got the data and you're able to compare groups side by side, and then you indicate if you discover certain disparities among these different groups, then working with those populations in your youth advisory councils, your family advisory councils, your community groups, right, these different convening sessions, is to have them help you with strategies on how to best make these improvements in the project. And so the strategies for gathering and interpreting the data in the first place include, again, looking at the U.S. Census, as we've looked at, using state-level data, looking at your services data, and also training evaluation data can be used to identify needs. Collaborating with community partners, youth, families, professional and community leaders, and service providers to gather any local data that may be available, and then making comparisons. Does our state, for example, or our catchment area look like the national trends overall? So once the data are, you're kind of casting the net wide, right? So you're seeing where you can pull data from to look at any breakout types of reports or comparisons among these different populations. And then once the data are collected from these various data sources, the disparities and disproportionalities are identified and interpreted to develop the strategies to enhance the behavioral health outcomes for the children, youth, and young adults that are receiving services in their families. So this is, the interpreted data is going to identify cultural enrichment needs of the community, gaps, as we've discussed, in services for minority and underserved populations, whether services provided are client-centered, that is, youth-guided and family-driven, and whether services provided are culturally and linguistically competent. And that means aligned with the culturally and linguistically appropriate service standards. There's an entire separate webinar about the CLAS standards that's available, but this is just a sort of overview and a resource for you that shows that the principal standard of the CLAS standards is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So to read more about what CLAS standards involves, there's a link that's provided here. So this is one way, this is one example of how several systems of care that we've worked with have lined up their behavioral health disparities impact statement as they've collected their data. They gather statistics on overall disparities and disproportionalities. For example, if they didn't have it for their local catchment area or their local service area, maybe they needed to look at their larger region, or maybe that's the state level data that are available. Statistics on program services that are identifying disparities and disproportionalities by county, by zip code, according to any types of breakout areas, breakout reports, where they're available. So, for example, local school systems may have a report on, student dropout, for example, by race, right, or by gender. So these are just examples of how, these things can be pulled together. And then there's So that's the kind of background of any types of reports that might be available in terms of what does it look like for the youth and families that are served by our project in our region, in our area, and in our state. And then what's the impact statement, right? Specific information regarding the subpopulations that are available in the area, U.S. Census data. What does the local service and catchment area look like? How many youth of a particular race or gender, ethnicity, are in our area? And then what's the data collection and reporting process that we're going to use? And then what are our plans for developing policies and procedures to address those disparities and disproportionalities? So for example, this is the NFusion system of care example, where they created a behavioral health disparities impact statement with a population of focus that included youth and young adults, ages 14 to 21, with severe emotional difficulties transitioning from children mental health services to adult mental health services, or from an institutional setting to the community. That's their sort of population of focus, right, who they're serving. And so what happened is that we started casting the net wide, right? We wanted to look at what does it look like for these youth and the families that are being served. What does the context look like in their local area? What are their mental health and behavioral health difficulties or needs? What's appropriate treatments that are available or not? Juvenile crime, mental health concurrence, training schools versus community services, mental health in the juvenile justice system, educational and attainment or dropout rates, teen pregnancy, unemployment, homelessness, or out-of-home placement. Right, this is like the laundry list of what can we get, what's out there in terms of any data that are available, right, for the youth across these types of topics. And again, the intent here is to look at how we can string together all these different systems of care. Right? Is there a way that do they all have reports of some kind on youth that are served? Oh, they do. Great. Do they have reports on any breakout reports that show, these types of needs among, by race, by gender, et cetera? Okay, so then you start to pull those types of things together. Another example is in terms of the use of U.S. Census data, is to compare the people who are being served with the representation in the local area. So for example, what we discovered in these different counties that are depicted here on the left, in the table to the left, we found that the Hispanic and Latino population was approximately 4.3%, 10.7%, or 13% within these counties. These are service areas of the system of care. And then we also found that there were languages other than English that are spoken at home, right? And there are minority populations that are being detected by the U.S. Census, right? So these are publicly available data. And then yet when we looked at the service utilization, right, among these populations, for example, the Hispanic and Latino population, you can see on the table to the right, there was really minimal engagement in the system of care services. So this is the power of using these types of data. It raises the question of, oh, well, we didn't know that we had populations that were, let's say over 10% in the local area. And it begs the question of, well, what can we do better to better serve this population? Because it looks like they're not engaging, as much as they can with the services that are available. Well, what we found is, for example, in this example, that more outreach was needed, and a Spanish interpreter was found to be helpful. So that then increased these numbers over time. So that's how you can use the disparities data to inform how the program is operating. And then we also found that African American youth and juvenile justice services were definitely, there was a disparity that we saw with that. So there was representation per county that was more than twice, far more than twice than all other youth combined. So there was a definite need, right, a disparate number of African American youth entering the juvenile justice system. So then, again, using the data, we're able to then follow up on strategies on how to best meet the needs of these youth. Another example is looking at the representation in the overall population. So for example, in these two counties, we looked at the Black or African American representation in the population, and saw that there were large percentages, over a third, if not upwards to approximately a half of the population was Black or African American. But what we found in terms of juvenile justice dispositions was that there was a very high number, right, that was happening. So there was a disproportionate impact of juvenile justice dispositions among the population given their representation in the overall community. Another example of how the use of these data can be made more friendly and accessible to your youth advisory groups, your family advisory groups, your local system of care representatives, and anyone else whose leadership, their system of care champions in your local area, is to create things like infographics. So in the projects that we work with, we created, here are just two examples. This is a pull-out report, right, where we're able to show breakouts in terms of educational needs or juvenile justice related involvement. Teen pregnancy, for example, is shown on the left, right? Snapshots that we could pull out from different reports. And then that then informed the discussions that were then followed up on with the feedback channels for those who are in the community and who are being served, right, to make sure that we're always looking at disparities and disproportionalities in ways that the system of care can be responsive to and address the needs of their populations of focus. The example on the right shows gang violence and substance abuse, for example. And these were specific topics that were requested by those exact groups, right? So they said, when we said, oh, well, we have, a sort of topic list of different things that we're looking at, what would be most helpful for you to look at? Well, one of the major topics that came to the top of mind for them was gang violence and substance abuse, because they had all kinds of different news reports and needs that were emerging in their community. So we then looked at the disparities around this, looked at any data that we could find around this so that we could then best inform the feedback channel to addressing those needs. Another example that we used is for gathering, interpreting, and utilizing disparities-related data on an ongoing basis. Well, you can do this through the cultural linguistic competence learning sessions, right, or trainings that are provided in your local area. Your CLC coordinator, for example, provides educational opportunities or spreads awareness around the needs of certain populations. So what we did is we lined up the before and the after responses on how people were supportive of addressing disparities and addressing cultural linguistic competence. And so what we showed was that the before graph, as shown on the very left on the red area on the slide, it was markedly different than the after graph that was transposed over it in terms of their support for addressing disparities as a result of the cultural linguistic competence learning sessions. So this is basically evaluating the effectiveness of those trainings, right, in terms of people's engagement and intention to make changes. And definitely kudos to Albertine Johnson Pickett in Mississippi, who travels all across the state and provides learning sessions. And this is data from those sessions. So the quantitative data are little things that are on the evaluation forms, asking before this session, where were you, and then where are you now? Well, that's one way to do that, as a sort of post-evaluation assessment. And then there can be open response items to ask, can you please provide an example of how to apply the information from these cultural linguistic competence CLC learning sessions? And you can gather statements and quotes where people will say that it was able to make them more efficient for coordinating services. It'll help them to be more mindful of differences when developing and planning treatment for diverse individuals. Right, all kinds of ways that you can utilize. What's the impact? So the essence here in terms of the behavioral health disparities impact statement is to describe how data will be used to manage the project and assure that continuous quality improvement, including the access to services, the use of services, and the outcomes related to those disparities that are identified. These data-driven strategies, as we mentioned, are really should be continuous, right, where there's regular data reports to project officers and project staff that identify disparities data. We showed those infographics, for example, in the previous slides, to use those types of infographics or data reports to have the assistance and discussion of the data with stakeholders, to work directly with the populations of focus to develop population-specific strategies for, how do we best address this? Not everyone has the exact guidebook on how to address a specific disparity. So the communities of focus or the populations of focus are the experts. So making sure there's a feedback channel directly from them and to them, to engage in that dialogue is important, and this is all data-driven. And then to have that client-centered feedback loop to influence positive aspects in service delivery. So what is our wish list, right? What is our sort of steps moving forward on how to make changes to address those disparities? Well, one, you've got to have the data, right? There's no action that can move forward other than a general sort of topic discussion to be able to measure changes over time unless you know about the populations of focus. So lots of forms, for example, are agency intake forms or any types of other demographic assessments. Lots of times they're old versions that are the Mental Health Services Agency, for example, has been using for decades or for many years, and it may collect data on race and gender, for example, but it doesn't have LGBT-related areas. So again, this is reflective of that population of focus and statement of need from the actual grant application. They asked about, do you know about the populations that you're serving across these different categories? So it leads to an ongoing, basically, discussion of monitoring, how are these people doing over time as they engage with the systems of care. If you're looking for an example of, for example, we received many TA requests on how to ask the questions for gender identity for people who are transgender, for example, or for sexual orientation, people who are LGBT. Sometimes we'll get questions that will say, well, we're not sure how to really address this topic, on our forums or how to ask these questions. Well, there's specific help that's out there. There's not only technical assistance that's available, but there's also standardized measures at a national level that can be adapted and used. And also looking at your anti-discrimination policy. So if you have staff, for example, your cultural linguistic competence coordinators, who want to be allies, right, to feel safe to be out as an ally, to say, I'm a champion for racial, ethnic, and minority, LGBT, underserved communities, right? Are they supported at work, right? So if your agency or organization has an anti-discrimination policy in place, well, that's the local protection that they have for being a champion, right, for being an ally. To look at partner agencies, so for example, maybe your organization has a very inclusive anti-discrimination policy, but the systems of care that you interact with, whether it may be the housing provider or the school system or juvenile justice or any other types of systems, right, where your clients or your population of focus engages with, maybe you're referring to them, they're referring into your project, right? Did they have inclusive policies? That's a question to ask when there's meetings, agenda items on meetings. And also to look at your vendor contracts. So for people who are contracting with your agency, do you have a standard in place that says, this is our standard anti-discrimination policy that's inclusive? So these are sort of prompt questions to ask and to raise. We also want to have safe zones or safe spaces for all youth. Right? This is not just one specific category of youth or people who are excluded or included, right? This is all youth. So we want systems of care to be a safe place, right, where people of different diverse backgrounds, ethnicities, sexual orientation, gender, et cetera, race, ethnicity, that they can come and feel welcome to services. So there are ways to do this, right, in terms of designating a safe zone, in terms of symbols or signage that's available. Sometimes they can be very colorful. There are examples that are depicted here in terms of rainbows or hands that are crossing and meeting in the middle together. There can be just a sort of general sign that says, this is a safe zone. For example, this space respects all aspects of people, including their race, ethnicity, gender expression, sexual orientation, socioeconomic background, age, religion, ability, etc., right? So some agencies or organizations will put this in their meeting rooms where the youth are. They'll put it in a drop-in center area, right on the wall, or common areas, conference areas, for example, where people are gathering, where they have their system of care meetings, for example. And so this is what is ideal for making it so there's a welcoming environment for different people of different different representation. And then to support individual personnel who self-identify as allies and promote those safe zones. And there are many other types of things that are available, that are listed here, that cultural linguistic competence coordinators, for example, when they engage with TA, sometimes they'll say, oh, we didn't know we could do, X, Y, or Z. Well, yeah, you certainly can. If you're helping the system of care become more diverse and inclusive, then, this is an allowable activity in terms of what their job description or their duties are. So to improve practices, knowledge, and engagement, there is a sort of list of things that can be done to identify training opportunities on an ongoing basis on specific topics, right, around disparities or disproportionalities. Youth homelessness might be the one topic, right, that comes to the forefront. And so by identifying training opportunities that are available for attendance, right, or requesting TA, or learning things online about those types of things. Suicide prevention among youth, for example, bullying, right, whatever specific topic it is that's leading to a disparity or representing a disparity or disproportionality. These are all parts of what systems of care are all about. To share the learning content, not only with the personnel within the system of care, but also these other systems, right, that you're referring into and receiving referrals from. Foster care families, schools, faith-based organizations are critically important for engaging youth across the system of care. Right, these are types of organizations in the larger system to just share those training opportunities and learning content with them as well. To develop those inclusive referrals, right, to update forms, to make it known that there's a policy in place, that it's a welcoming environment for diverse youth and families, to partner with community alliances, and then to celebrate successes, right? This is always very important because Health and Human Services are sometimes, it can be thankless sometimes, or there can be criticisms, right? There's always ongoing needs, right? So to really recognize the successes, right, that occurred because of diversity and inclusion. Well, we were able to adjust our program to be more welcoming to a certain population of focus, and we were able to have staff receive a training on this, and they went out into the community, and we had much higher enrollment, right? So that's one success story, an example. To provide self-assessment tools that are available. Sometimes staff may have implicit or unintended biases, for example. So maybe they have discomfort with working with diverse populations, or even rejection or a stigma, right? So self-assessment tools can be used to kind of understand or gauge where are people at on this. Are they ready to go with conducting outreach to diverse populations? Are they where are they at, and how can we help to provide training and other opportunities? To do asset mapping, right, to have diversity or climate surveys, for example, to develop train-the-trainer resources, connect with other systems of care to identify inclusive service models. So maybe there's another system of care that did a really great job engaging with a certain population of focus, and you want to learn about how they were able to do that successfully. So reaching out to another system of care is also important, and we can certainly help to facilitate those connections at the TA network. and then to conduct social marketing activities to change voluntary behavior toward acceptance and inclusion. Right? So that's what we're kind of really trying to help along here is social marketing, the behavioral changes toward acceptance and inclusion of diverse youth and families. So that is, in summary, what we're looking at in terms of behavioral health disparities impact statements. I want to thank everyone for attending, and we can open up the line for questions. There's a resource here for anything specifically. Maybe it's a specific population of focus that you want to learn more about, specific racial, ethnic group, or LGBT population. There's a link provided here for visiting the website, and there's lots of resources in the resource library for that are available. Thank you.
Well, great. Thank you so much, Peter. There are a few questions here that I'd like to pose to you. One came from Denise Atchin earlier, who wanted you to clarify what difference in percent of the general population and percent in a specific population would meet criteria for actually being a disproportionality.
Oh, yeah. So I provided examples of the extreme versions, right? So let's say a minority population of, racial ethnic minority population represents, let's say, 10% of the statewide population or the service area, the local service area. According to the U.S. Census, they're 10% of the population. And then if you look at, their behavioral health related needs or their involvement in a, let's say criminal justice or juvenile justice, and you see that among that system that there's a disproportionate impact among that population, let's say it's 50%, right? Then, that a racial ethnic minority group is represented as 50% of all juvenile justice cases, for example. That's a pretty clear, disparity or disproportionality related issue to look into, and the systems of care can address. In terms of the threshold, there really isn't a specific, threshold. It's really a difference. It's a qualitative difference. So let's say it's 10% of the population, but but it's 15% in juvenile justice. Well, that's still a difference, right? So it's something that you can look at the extremes or you can look at the margins, but it really can help to prioritize what populations are most impacted by a certain issue, and then starting there, and then working on other populations of focus. So in Mississippi, for example, African American youth in the juvenile justice system is the top issue, right? And then it's the next population of focus is Hispanic youth. It's other population groups. So that's one way that you can prioritize, because this can become a sort of laundry list, of lots of different social needs and different things. But you got to start somewhere. So starting where there's the most extreme impact, I think, is it really jumps out. I think you'll find that in many different areas, and that's the place I think is the place to start. And working with the youth and families where maybe it's specific that their advocacy is that they want to really focus on, for example, we talked about gang involvement because it was a hot topic in the area. They've had really tragic events that have happened, that people are really concerned about in their community. So maybe that's the where that they're setting the tone in terms of priority as well. So there really isn't a specific percent or specific comparison in terms of numbers, but there's a process. I would say would be the approach to follow.
Okay, great. Thanks, Peter. Another question is around strategies for working with partner agencies to be able to begin getting some data on disparities. A couple of people mentioned that they are able to get Medicaid data, and a couple of others from juvenile justice. Have you encountered systems of care that have used successful strategies for obtaining data from partner agencies, and do you have examples of that?
Absolutely, and so this is really it's essential for systems of care to hold work groups, convening groups with other service systems. So, for example, housing and juvenile justice in the schools, and wherever youth are served by these different service systems, to basically to raise it as an agenda item, that we're finding that there are lots of youth, for example, in our area who are having challenges with, a certain issue. For example, if it's juvenile justice, right? Lots of our referred youth are coming in with histories of juvenile justice involvement. So reaching out across the table to the juvenile justice representative or the person who's the person in charge, or can have a request made internally for those data, to then start to line up the data to show, this is what we see in our system of care, and you've got a breakout by gender, by race, by ethnicity, by LGBT, for example, and you can use that to sort of push the report, a snapshot report across the table and say, well, this is what we're finding. Do you see this in your system? Do you collect data, according to these categories? And if they say, oh, yeah, we do. We have a, report that's available by gender. We can pull the, the overall summary by race, or, et cetera, but we don't maybe, for example, collect LGBT-related data. Well, that's an opportunity for sharing best practices, right, for how the system of care is doing that. And this is something that they can look into, making changes in their own system. Or, that's something that they can put into, their data requests, right? So it's this ongoing dialogue. All these data systems are very different, right? We know that it's not some magical database that has everything all neat and clean and lined up together. You have to kind of work with your partners to, to show them, well, we have the model, right? So systems of care are the model of diversity and inclusion, and this is how we are doing our breakout reports, and then sharing that with them and getting that dialogue going on how they can, line up with that and share across those types of indicators.
Okay, great, thank you. Another question was around examples of disparities impact plans. Does the library have specific examples from states or communities of their actual impact statements that other people could see?
Yeah, it absolutely does, and I'm happy to provide specific examples as well of many different projects I've worked with. So, you can contact me directly at that email address there, and I'm happy to share that with you directly. I can send you a link to a file. Sometimes these PDF files will get large because they have lots of data or graphs or charts or whatever, but if I'm not able to email the actual file out directly, I can send a link to it.
Well, actually, that would be great. Yeah, and if you send that to us at the Institute, we can send that out to all the attendees, along with the recording of the webinar and the resources for download that are already there. So that would be great. Any of those that you can send to us, we can get out to everybody who is on the call. Another question from Shannon Moreno is about how you handle it when a disparity is suspected within a very specific ethnic group. You can see in the chat box she's referring to Hmong disparities, but they are aggregated with Asian American or Pacific Islanders or in a category called other. How do you capture that kind of a group without partners feeling that there's a burden to collect additional data?
Well, that's always the trade-off in looking at data, is that there's the burden of data collection in terms of time and resources, right, invested into updating forms or data systems or processes, right, in terms of asking questions when there's an intake session, for example, or a follow-up interviews. So there is a sort of investment, right? As an evaluator, I would not characterize things as a burden, but I would say it's an investment, right? So there's, if there's a level of importance that raises to the top that is needed in terms of advocating for a change, then do it, right? So then make those requests, right? Lean on the edge of making those changes, because you want to find out, you're hearing maybe anecdotally that there's a certain minority group that is having a really hard time, right? And it's becoming not just the one story or the 2 stories or the 10 stories. All of a sudden you're hearing from lots of different people, this is a trend, right? So then it becomes, well, if this is a trend, then we put a data channel on it, right? Let's investigate, let's kind of dig into this a bit to look more at this. to what extent is this a problem? Is it affecting, a large percentage of this population, of this subpopulation, or this specific population group? Is it a specific breakout report that we need to generate? Is it something that we can do to, to learn more about? Do we need to have maybe just a focus group on this with specific representatives from the community, who can come in and talk about their needs, right? So maybe it's, the ideal is to have a systems change in place where forms are changed or data systems are changed, but maybe you have to go at it a different way and hold a focus group, right, to collect that information and devise strategies on how the system of care can be more responsive to their needs. I think that's the approach.
Great. Okay, looks like we have maybe another question coming in from Andrea. Others, if people would put other questions in the chat box, these are, I think, great questions and lead to a good discussion about this.
Yeah,
okay,
so
looks
these
like
are
a couple more coming in.
There's the initial submission to the government project officer that's due when the project first begins, and so that kind of sets the tone or the template for, what's the plan for inclusive data collection. And then, you don't want it to kind of sit on a shelf and collect dust, right? You want to kind of update it and use it and make the data live, right, and usable. So that's why you want to, have these updates to the data on an ongoing basis, and then have that live channel of feedback from the communities that are most affected. That's the power and the use of this.
Right. I think that's an important point, that these are not just about creating statements, but using these to create strategies for system change. So I think that, of course, is the intent of these, and I think it's important for everybody to keep that in mind, that it's not just another plan or just another statement, but something that's really intended to be applied in a system of care. We still have a closing remarks or anything that you'd like to add.
No, just to mention that, we're here to provide support and help. This isn't a sort of, gotcha issue or a requirement-driven issue, that it's something negative or in any way, to put this together, to look at disparities and disproportionalities. This is all about continuous quality improvement. It's about helping the populations that are most in need and with the challenges or the needs that they have, and addressing them in a way that can kind of show the extent of changes over time. So that's really I just wanted to mention that this is not, kind of an administrative burden or challenge or anything else, but we're here to help. We want all the systems of care to be model systems that really do the best that they can for the communities that they're serving.
Right. So it looks like we don't have any more questions, and we'll end a few minutes early. Let me take an opportunity to thank you, Peter, so much for sharing your expertise. I think this has been really informative, very, I think, concrete strategies, as I said, for making these plans come to life, and to take a deeper dive into this that goes beyond just submitting a document, but really using this as a basis for action. So thank you very much for doing that. A reminder that we will be sending out some materials to you. We'll look for those from Peter, some sample plans, and also to use the library that's on this slide to access a whole range of resources around cultural competence and disparities. And to remind you that the TA network has a hub on cultural and linguistic competence, and we have TA providers and consultants in that hub that are available to you to help with your work in these areas. And I want to remind all of you that our next meeting is October 25th. It's going to focus on state-community partnerships for system of care expansion, which I think is a very important issue, and we will be providing some general information, a framework for state-community partnerships, and then also have examples from dyads of communities and states in 2 jurisdictions that have worked together very effectively to reach the shared goals of expanding systems of care. So with that, let me thank all of you for participating and hanging in with us until the end. And we look forward to seeing you again October 25th for our next Learning Community meeting. Thank you all.